Okay, thank you, Philippe, and thanks to the organizer for inviting me to speak about factor VII deficiency. I called it from fundamental to bedside, but it will not be the framework of my talk. These are my disclosure in nothing already. First, factor VII deficiency is rare. It's a rare bleeding disorder, but among the rare bleeding disorder, it's probably it's one of the most frequent associated with factor XI deficiency. It's very difficult to have a true prevalence of factor VII deficiency. It's around 1 for 500,000 patients. So we shall study all this link between genotype, biological phenotype, and clinical phenotype. First, if we see the clinical picture of factor VII deficiency, you have some particularity. At first, you see that there are a lot of asymptomatic, and probably the amount of asymptomatic patient is more than 10%, because it's difficult to know how many asymptomatic you have to detect them, and how can you detect them if they are asymptomatic. So probably it's higher. That's the first problem. We should come back to this asymptomatic. Then you see the most frequent are epistaxis, easy bruising, menorrhagia, and gum bleeding. Then you have hemarthrosis that we know very well in hemophilia and muscle hematoma, gastrointestinal bleeding, chronic arthropathy, and then rare but very important are CNS bleeding that we saw with the lecture of Diane, and we see them in factor VII deficiency. There are also thrombotic episodes we published on this fact, but I will not come back to this problem, which is difficult. Oh, no. So if we look, if we can summarize the specificity of factor VII deficiency is, first, we have CNS bleeding. When I say characteristic of course, we know that there are other deficiency where you may have CNS bleeding, like factor 13 or so on, but it seems frequent in some kind of mutation. Then you have hemarthrosis and hematoma. I call them hemophilia type. We know this kind of complication in hemophilia. And then we have what I call primary hemostasis type, which is menorrhagia, epistaxis, and ecchymosis. That is mucosal bleeding. So you have both type, which is very, very strange, and probably is due to the physiology of factor VII, and we have a lot of asymptomatic patients. Is it different? Do we have a different phenotype, clinical phenotype between males and females? If you exclude menorrhagia, you have the same frequency of symptoms according to males or females. So probably there is no hormonal influence on the phenotype. Then if we go to the biology, we still have some, we should try to find a link between biology and the type of symptoms. There is no real link. You see that the symptoms are present whatever the level, whatever be the level of factor VII. The most frequent are menorrhagia, epistaxis, and you see them at all level. An exception is hemarthrosis that you see mainly in patients who are less than 2% of factor VII. The first, one of the main problems in factor VII deficiency is that there is a poor correlation, nearly no correlation, poor correlation between factor VII level and clinical symptoms. We know that some patients may have less than 1% and be asymptomatic or paucisymptomatic. We had a lot of examples in our registry and in other registries of surgery without substitution in patients with factor VII less than 10%, and there are 80% who had no complication. And this raised the question of what is the threshold value to substitute in patients who go to surgery. The problem is always the same. The patient had the surgery to detect the factor VII deficiency, and you see that before he had 2 or 3 surgeries without any problem. But when you detect that they have factor VII deficiency, nobody go to surgery without substitution. And probably, and I shall come back to that, very low level of circulating factor VII might be protective. And there is another problem which makes the situation more complicated is that there are different results according to the thromboplastin used. And the problem is to know which is, to try to know which is the most predictive according to the reagent you use. An illustration of that is, I took one, but we have others, factor VII Padova in Italy, which is in Italy. It's a moderate hemorrhagic diastasis. According to the test, the reagent you use, you may find 100% or you may find 9%. So what do you take when the clinician asks you what is the severity of the disease? You say, well, take what you want. Either is normal or is rather severe. And in this case it's true, but in our registry it's true also. Probably the human thromboplastin is much more correlated with the clinical severity. So I asked the question, what is the threshold value under which you may have bleeding complication? And this is interesting. This is a work which was done by Muriel Giancilli-Blaiseau. And you see that they use plasma depleted in factor VII and make the thrombin generation test. And see, if you see the different level, you see that for a level of 10% here, okay, you have nearly a normal TGT. So in a theoretical view, maybe that 10% is sufficient to normalize hemostasis. And what is interesting is by another way, totally different, we looked for 42 patients with factor VII deficiency, and we tried to see among this small series, and now we have a larger series, what was the threshold value coming from the clinical data. And we found the same. We found 8%. So probably there is a threshold value about 8 to 10% for the severity of the disease and for bleeding. This is very interesting. Now, as I told you, there is no, you cannot expect from the factor VII level to predict the risk of bleeding. So we tried in a series of work to determine whether we could find any factor that can modify the clinical phenotype. And we studied activable factor VII. That means you have few factor VII circulating, but you can activate it. We tested inhibitors, TFPI, protein C, antithrombin, and we tested Wilman factor, platelet function, other coagulation factor. The patients were divided into two stages, the asymptomatic and the symptomatic, and we compared all these factors in both series. So these were the tests that was performed in asymptomatic and symptomatic, activable factor VII, factogen, TFPI, protein C, antithrombin, APCF, FVII laden, HER2 polymorphism, Willebrand, coagulation factor level, thrombin generation test. None of these tests was able to predict the risk. So none of these parameters is likely to influence the clinical severity. What about come back to thrombin generation test? And this is also a poor result. It was interesting, only 2 patients, but they were sister and brother. They had the same genotype, of course, and the same TGT. This is a TGT of the control. TGT of the brother and the sister, identical. That means that from the genotype, you may have a kind of structure of TGT, and one was totally asymptomatic, and the sister has hemorrhagic diastasis, not only menorrhagia. So the TGT, in this case, the TGT is unable to predict the severity. Just come back to the link to the treatment, because from what we saw, we may link some conclusion for the treatment. We have four kind of treatment. There is a factor VII concentrate, which is called Mu7, which is not available in all countries. And you have the vial has 600 units in 10 ml. 1 unit by kilo increase the factor plasma level of 2%, and half-life is 4 to 6 hours. And the other is NOVA7. But if you come back to NOVA7, you see that the doses necessary to stop the bleeding are very low. And in the recommendation, it is said 30 microgram by kilo, but you may use 15 or less 10 microgram by kilo. It's enough. If you consider the amount of factors of NOVA7 that you have to use in hemophilia with inhibitor, it's very low. So it confirmed that we need very, very few level of factor 7, not as few as in factor 13, but very few level to have hemostasis. Then if you don't have these drugs, you may use prothrombin complex concentrate or, of course, fresh frozen plasma. Now we've got to go to genotype and to learn see what we can learn from genotype, from genetics. From the genotype, you may have two consequences. You have two kinds of abnormalities, either polymorphism or mutations. First, let's come back to the factor 7 gene. It's on chromosome 13 in Q34, and you have 8 exons. The mRNA is there, and then the mature protein is 406 amino acids. Each exon, of course, is responsible of a zone. And if you consider the factor 7 gene, you have the prepropeptide, which will be dropped, and then you have the light chain, disulfide bond here, and the heavy chain. And here is the link between the light chain and the heavy chain. And you have the exon 8 for catalytic domain, activation region. I shall come back to that because it's interesting. It's important to understand the consequence of genotype. So the main region are the catalytic domain, of course, the activation region. There are two EGF-like domain, 1 and 2, and the GLA domain, which allow to fix calcium. First, let's consider polymorphism. A lot of polymorphism have been described in factor 7. Don't try to look at that to illustrate all the polymorphism that have been described in the factor 7. And what is important is the place of polymorphism. As you see, they may occur anywhere, here, here, here. And the Bernardi show this event was that one third of the variation of plasma label come from polymorphism. So if you only consider the genotype and the mutations, the causal mutation, you will not be able to predict the level of the final level of factor 7 because you will be sensitive to the polymorphism. Now let's come to the causal mutation. This is the factor 7 molecule. You have the catalytic domain, the site of cleavage. The more important are the catalytic domain, the site of cleavage, and here, this zone, which is the disulfide bond. Then you have EGF-1,2 and GLA domain and processing protease. These are some of the mutations that have been described, and I shall focus on two mutations, this one and this one, because this, it will help to understand the consequence. Here I took two mutations, one which is just on the cleavage site, and one is just on the disulfide bond. If there is this mutation or this mutation, you have a very severe consequence. I mean that here the molecule is quietly destroyed and you have no molecule. So we can define severe mutation, I took two, or you have a mild mutation that may occur here or here. So we have other examples, of course, but we have some mutation that we can classify as severe and other which we can classify as mild. Now, coming to the genotype, this is a normal one with the red and the orange, and this is in pink. This is a mutated, a causal mutation, mutated gene for factor 7. So you may be normal, you may be heterozygous, homozygous, or compound heterozygous. But from that, you will not be able to understand the consequence. because you must consider also the fact that in the mutated gene, you may have severe mutation or mild mutation. What are the severe mutation? A nonsense mutation, of course, because you will have no molecule coming from this gene. You will have no molecule, no factor VII. Complete or large deletion, again, no factor VII circulating. Frameshift mutation, we know that in a lot of situations, frameshift mutation, you have no molecule. And some missense mutation that I described previously, the mutation occurring on the catalytic domain, or the mutation occurring on the disulfide feed bound. And then you have in gray, the mild mutation. Point mutation like this one, which is very, very frequent, a la VII mutation, and short deletion. So in the mutation, we have the severe and the mild. Then you can build the genotype with that. First, this is normal. This is a normal gene, and you may have a normal gene with a mild mutation, or a normal gene with a severe mutation. The consequences are the same because this gene may produce normal factor VII. So the consequences, even if you find in your genotype a severe mutation, that doesn't mean that it will be a severe lesion because you have the other, which is normal. So the phenotype, whatever be the mutation associated with in a heterozygous type, is asymptomatic or mild clinical phenotype. Now, let us consider if you have two mild mutations or a mild and a severe, then you will have a mild clinical phenotype because this mild mutation, of course, induce a factor VII deficiency, but you still have few factor VII produced by the gene. So it is enough to make from this genotype a mild clinical phenotype. Then the more severe, if you have two severe mutations, or here is an homozygous, here is compound heterozygous or another heterozygous, these are very severe clinical phenotype. And in this phenotype, you may have CNS bleeding, you may have hematolosis, and so on. And this is very important to consider because imagine you have a patient who has few symptoms, and you make the genotype, and then from the genotype you find that the genotype is severe. You will go very, very quickly to prophylaxis because you know that in this kind of situation, probably the patient will have a severe phenotype, and you don't have to. You are not allowed to wait. Of course, in hemophilia, you can wait the first hematolosis, but in this patient, you know that some of them will have CNS bleeding. So in this situation, if the patient has some symptoms and you see a severe genotype, so you will go, we should recommend to go to rapid prophylaxis to avoid the first CNS bleeding, which can be the last. And this is one of the consequences. Finally, to conclude, first, factor VII deficiency is highly heterogeneous. Heterogeneous in the clinical phenotype, heterogeneous in the biological phenotype, and I gave you the difficulties of obtaining good information from biology because, as you see, it will depend on the reagent you use. And then it's heterogeneous in the genotype with all the kind of mutation, mild, severe, or other. And the link between gene, protein, and disease is a variable. And maybe there are other components that are involved, not the one that we tested, but maybe other that we could not test. And we must try to see which are the components that induce severe clinical phenotype or not. In some cases, genotype may help therapeutic choice. This is for a very important message. The decision prophylaxis may be help. I don't want to say that you take the gene and you decide prophylaxis. I say that this is an important information in your decision, the type of gene. Genotype may be used also for genetic counseling, but you need at this moment to have the genotype before the pregnancy. Genotype is unable to predict the hemorrhagic risk. No, that's what I want to say. It may be a tool, but it's not sufficient to predict the hemorrhagic risk. And at this time, we don't have true data, true value to predict the hemorrhagic risk in a patient. And you will see in your practice, patient with a very low factor VII, 2%, 1%, without any bleeding. So this is a rule for all the rare bleeding disorder. We need international registry because all of us have a very limited series, and what is true for factor 13, factor 7, factor 11. We need international registry. We need large series to have good information. And I think that now there are registries actually that Philips know very well. Finally, I want to acknowledge my colleague from the Laboratory of Hematology in Montpellier University Hospital, Christine Biron-Riadry, Patricia Aguilar-Martinez, and mainly Muriel Gensili-Blaiseau, who was the first author in most of the papers and who knows factor VII from the beginning to the end, and the French group on factor VII deficiency and the steering committee with Guglielmo Mariani and Francesco Bernardi. Thank you for all attention.